On the lake, the deep forbidden lake, the old boats go gliding by, and the leaves are falling from the trees and landing on the logs, and I see the turtles heading for the ball and falling off the log. They make the water splash, and feeling no backlash, they climb the happy banks.
Hi, this is Dr. Park, and I'm recording the last of my lectures. This is part 9 of 9. What is Dr. Proch's approach to exosome use? Just to recap, the other lectures in the series that are available are number 1, Introduction to Exosomes, 2, Aging, 3, Parabiosis, 4, Cancer, 5, Regenerative Joint Therapy, 6, Are All Exosomes Created Equal, 7, the FDA, 8, Risks and Benefits, and finally this lecture, How Do I Use Exosomes? Briefly recapping my background, I went to Harvard undergraduate in anthropology and went to medical school thereafter, studying medicine and a joint degree in public health. I returned to Harvard for an OBGYN residency at the Harvard Teaching Hospital of Beth Israel. I have attended a conference on ultrasound-guided injection of joints. This is a 2-day symposium on needle localization in real time, and this helped me a great deal. I am completing education on geriatrics, joint disease, Alzheimer's, back disorders, autoimmune diseases, and other central nervous system conditions, as well as being a voracious reader and thinker around these topics. I believe that my mission is to help people, if they so desire, to regenerate and recover and fight the effects of aging and the inevitable chronic diseases that are associated with that. My ethics dictate that I will always be honest, always provide informed consent, and give you the autonomy to make your own choices. My general beliefs around exosomes and regenerative medicine come from my own experience, largely, and is only being strengthened by my experience with patients. In other words, I eat my own cooking. Before I embarked on this journey, I and my mother injected ourselves with multiple doses of exosomes through multiple avenues to see what the effects would be and to make sure they were safe and that I could understand and explain them to patients. So I do think there's a Hawaiian word called kuleana, which is better than our traditional dichotomy of rights and responsibilities. Rights are entitlements, responsibilities are obligations. But in fact, in kuleana, it's both. You cannot have a relationship without rights and responsibilities. I believe that the physician-patient relationship is just that kind of relationship in which I am obligated to do my best, but so are you, in terms of being honest and open about expectations and about understanding. A lot of this bases upon my 12 years of TA65 experience. In 2007, I started taking it. In 2008, I became the first doctor to prescribe, if you will, telomerase activators. Since then, I've monitored my patients for changes. Some of them are objectively measurable. A lot of them are anecdotal and appear on my YouTube videos. These changes would come about when multiple people told me they had an improvement, usually. If one person or two people said it, I would just file it away. But when 3 or more people reported the same results, we did a podcast. And these range in topics with depression, addiction, sports injury, cancer, a bunch of other conditions that can all be explored in about 50 podcasts on YouTube. Just search Dr. Park 65 or DRPARK 65. So I know that anecdotes are not clinical trials, And yet, when the evidence accumulates that certain people are experiencing certain changes, it is compelling and of interest. So, I do have a special email list where I share clinical experience with exosome clients and myself. This is for a non-public list, and the reason for that is because we don't want to advertise anything, and that would be concerning to the Federal Trade Commission and not beneficial to people at large. So once you enter into the email list, you will be trusted with keeping this private. There's no obligation to purchase. There's no hard sell technique. It's simply that I want to know with whom I am conversing and for what reason. I do offer general age assessments, which we have a state-of-the-art technique. I anticipate most people will decline this. They don't want to pay the extra money to know, but it is available. This consists of a complete history and directed physical examination. And then we have what's called physio-age assessment, which is a proprietary method of measuring your pulse wave pressure, your lung capacity, your skin thickness, and your mental sharpness in terms of memory, time, flexibility, and it's called CNS vital signs. We can also do vision assessments. What you're looking at on the right is my assessment from last year, showing that my physiological age after 12 years of TA65 is 31 years. Now, I don't necessarily believe that, but occasionally I do get carded. That aside, my cardio age was 31, my lung age 42, my neurological age 22, and my skin thickness 39 years. So the histogram showing that last year I was 51, most of my bars were green and lower, which is welcome news. We can measure your telomeres. This is a measurement from last year, 2018, showing that my lymphocyte telomeres remain quite long, and that, of course, is associated with longevity and hopefully decreased morbidity. What just became available last year is Dr. Stephen Horvath's Epigenetic Clock. A company that I'm familiar with in Irvine, California, has improved upon the model, and they have a greater than 95% correlation, meaning if you just look at the epigenetic age or the DNA age, it will be able to predict your calendar age in a straight line way. And this in biology is very, very unusual. Of course, you see my result here is not accurate. What I did was I tried to send them a falsified statement saying that I was 20, and they nailed me at 44, which means that it's on the up and up. They're not using your chronological age to give you a biological age. So at the age of 51, I was epigenetically 44, according to them. This test is known as the My DNA Age test. A third blood test associated with aging would be the immune senescence test, which is done out of UCLA School of Medicine. It measures the CD28 negative cells. These are the senescent ones, the ones that are incapable of responding to new immunological threats, and also the CD95 negative. These are naive cells that are capable of responding to new threats. And here you can see in my measurements, what we have is a relatively low number, 18% of burnt out cells, and a relatively high number, 41% at the bottom here, of naive or flexible, usable T cells. Treatment is given IV. Blood draws are possible at the same time to do any of the immune senescence, epigenetic, or telomere age tests. We can also infuse them slowly with IV, although there is no need because there is no clumping, as in with the case of mesenchymal stem cell therapies. They are very effective globally. They're so small that they go everywhere. They're smaller than viruses, and a lot of where they go will depend on where the blood flow and existing inflammation are. Just in case, I have smelling salts, antihistamines, epinephrine, everything for an anaphylaxis protocol. I can measure your pulse oximeter, give you airway dilators like albuterol, and even have a automatic defibrillator should that become necessary. Intranasal treatment is something that is a little more perhaps high risk. The reason I say that is because it goes directly into the brain, but of course that is exactly where we want the action to take place. This is not FDA approved. Some people would think this risky move, but of course if we do nothing, the brain is aging, and some people without any other recourse, they really need some kind of help. Whether this will be that help, of course I cannot and would not say. But if you do want to rejuvenate the biological clock and rejuvenate the brain and the hypothalamic pituitary axis, then you do have practical ready access by injecting submucosally near the nasal turbinates. Basically, that's a fancy way of saying you inject it not into the nose, but right under the mucous lining of the nose, and it will be tracked back through the olfactory bulb into the brain. We use topical anesthesia after sterilization with iodine, and this is to decrease the bacterial count and risk of infection and to make the procedure more tolerable by viscous lidocaine. Very tiny gauge needle, 30 gauge is used, it's barely felt, and again that is able to get the exosomes where they need to be. Relatively painless, some slight sneezing, maybe some tearing, and a low risk of infection due to the bacteriostatic and anti-inflammatory properties, as well as the field sterilization. We can also apply them topically. The FDA is usually agnostic for topical use of most things because they're limited in their absorption through the thickened stratum corneum. This layer of anuclear dead cells is a barrier to the outside world, so you can pretty much smear a lot of things on your skin, and as long as it's not dangerous, the FDA won't say much. There's some anecdotal reports of success for conditions such as rejuvenation, burns, rosacea, and vitiligo. Of course, this is not FDA approved, nor is it a disease prevention or treatment claim. Some doctors are claiming some positive results. Finally, if you are going to do one of these facials that involves microdermabrasion or even fractional laser, which penetrates down into the dermis, then it's like aerating a golf green. And you can actually get systemic blood levels, but more importantly, the exosomes can be delivered into the deep dermal layer, which is alive, which has nuclei, which is reproducing. And Dr. Sanders of Florida has a YouTube video there which he describes the technique, and he's reporting some good success both for chemical peel and for mechanical / laser dermabrasion and needling as an adjuvant to enhance that efficacy. The therapy for in the joints or intra-articular or periarticular around the tendons is fairly straightforward, but you have to review the medical images as anatomical aberrations can exist and might be best understood by looking at x-rays, MRIs, and the like. In real time, we use ultrasound evaluation to mark the landmarks with a surgical pen. Of course, if you're dealing with knuckles, you can see them, but many times in the vertebral area or in the knees, the anatomy could vary. It's very important to know that you're using, in general, a bevel down technique to reduce trauma when you puncture the joint capsule. And you need to have sharp needles of adequate length, guided in real time by ultrasound in many cases. It's important to know where the trouble spots are, where the nerves, where the major vessels are. You don't want to get into trouble by injecting a sharp object in a dangerous area. And that's important to know what the normal anatomy is, to be able to recognize abnormal fluid accumulations and calcifications, as well as to recognize aberrant or abnormal anatomy when it presents itself. Absolutely important that, at least in the initial identification and marking of landmarks in the spinal areas, you need to be able to see and can very easily see with a bedside ultrasound the major locations of the vertebral bodies, and that will help you in localizing exactly where you need to go to inject either epidurally, intrathecally, uh, around the nerve roots, or around the paraspinal muscles, both retroperitoneally, like the psoas, or uh, extraperitoneally, like the paraspinal muscles. Injection into tendons and nerves is pretty straightforward. You go to the point of maximal tenderness, of being cognizant of vasculature or nerves to avoid. It's important to review medical records, using a surgical pen to mark the landmarks before sterilization, and then using an ultrasound in real time can be helpful in certain areas. You can do it without local anesthesia in many cases. Never use epinephrine, but oftentimes a tiny gauge needle with local anesthesia will make the patient more comfortable and not hinder the efficacy, but rather help it. I have a wide variety of needles, of lengths and different sizes, one for each sort of job, multiple choices, and oftentimes we need to do multiple injection sites along a highly affected area like the shoulder, for example. As we conclude this 9-part series, I want to thank you and let you know that this is for educational purposes only. Perhaps someday soon nobody will be using exosomes. Perhaps someday soon it will be growing in popularity, but again, only under the aegis of a patient-physician relationship. Really don't think that this is coming to you through the FDA in mass production anytime soon. Having said that, it's important to realize that everyone is different, including me. When I did exosome injection intranasally, the first time I did it was quite different from the second. And when I did IV therapy the first time, it was quite different. So it's important that a doctor is listening, is understanding, is paying attention to things that perhaps you don't even pay attention to. And of course, it's an art, not a science. We have to take into account that our theories could be incomplete or wrong, and so it very much is an art to practice clinical medicine. So every condition requires careful risk-benefit consideration. It requires you to think about how you perceive risk, whether it's of any benefit, and how you want to proceed, and it's my job to do that with you. Follow-up is very important for optimization. We need to know what your symptoms mean, what improvement means. Yes, placebo is very real, but also nocebo effect, or the belief that nothing will happen. And most intriguing is when things happen in places that make sense, but only if you consider why they were damaged and why they should be tingling or repairing now, many years later. I like to watch House, and one of the funny lines was, "What's the opposite of thank you?" Of course, as with raising children, a lot of times the relationship between a patient and physician can be challenging and confusing. A lot of times patients don't recognize what good care is because they're confused by honesty. Sometimes patients come at you for different reasons, but the main focus is that you should be all, as with parenting, on the same page, heading towards a common benefit. Of course, finding the hidden clues is not always that easy, so it requires a good rapport, and in most cases, if somebody has unrealistic expectations or a personality style that does not communicate well with my own, it will not be in anyone's best interests to proceed. If you're thinking about risk, and if your main concern is about risk, then I would say doing a non-FDA approved treatment is definitely not for you. I refer you back to lecture 8 about the risks of exosomes, and of course, you know, the risk of getting old and dying is approaching 100%. So this is only for people who have the ability to consider what it means to get old, consider the science and to take a little bit of a calculated risk. If together, as a patient and a physician, we feel that the risks are understood and the benefits are there, outweighing possible risks, then we might proceed with exosome therapy in its various forms. Of course, the idea that this will be beneficial is largely empirical. I would not call it evidence-based of the highest nature, although there are some compelling stories out there which can be hopefully replicated. So I would say this is not even rising to the level of experimental, but rather something that you would choose to do because you understand the science, are willing to accept the unexpected, and hope for the best within measurable and definable criteria. If you want to learn more about my basic theories of aging and become part of my blog subscriber lists, then go to rechargebiomedical.com. If you want to learn about exosomes in particular, you'll need to email me personally, and I need to get to know you, to know who you are and what you expect, and have some kind of relationship with you, because I do not want to be in the business of leading people astray, nor be confused or confusing to anyone. The price will vary depending on how many vials, of what concentration, and in which sites, and by what methodology. I am California based. I can make house calls in California. There is a general bias I have towards treating aging, and we have those tests to measure objectively how old you are and functionally how old you are, consisting of epigenetic, telomere, and immune age, and also the physio-age suite of testing. Also find it useful to inject old problematic joints and tendons, as well as potentially muscles that are in crisis, and that's very often possible with ultrasound guidance. Again, we measure aging objectively if you choose that. I believe there's synergy with telomerase activators and adaptogens, so we can offer that as part of your regimen. And also, we can offer senolytics, which is an entirely different area of interest and discussion that I will not cover in these exosome lectures. Exosome anecdotes, they're very interesting. I don't know if I can trust everyone. I don't know if I can even trust myself and my patients. But over the course of time, as in the case with TA65 and then other adaptogens like Recharge, a certain clinical experience and clusters of experience emerge, and that is really the goal. There's no one size fits all. Everyone is different. Even in time, different effects can be anticipated. So it's very important to work with a competent physician with whom you communicate well in order to get the best results. As I mentioned, if you want to be included on the private email list regarding exosome therapy, please send me an email to drpark@rechargebiomedical.com and expect to be phoned by me. I'd like to know who you are, because even if you never get a treatment, I still like to know with whom I'm speaking and for what reason. Anyway, this is Dr. Ed Park. AMA used to be American Medical Association. From where I'm standing in terms of my clinical practice and rejuvenation, it really means more ask me anything. I think you'll find if you reach out by email or phone call, I'm very accessible. I'm open to admit what it is that I don't know. And if that's a style that works for you, and if you're interested in possibly trying out exosomes, I would encourage you to first get on the list and learn more, and then we can open up that conversation. So this is Dr. Ed Park, again, completing a 9-part series on exosomes. I hope you found something of use in here. I am excited. I think that under the aegis of a patient-physician relationship, I believe that many will be helped by this modality, And I look forward to meeting you and talking to you and potentially helping you or your loved ones as well. Thank you very much.
On the boats, the old and creaky boats, the shoreline goes gliding by, and the wind that was a dying breeze is making the banners fly. See the colors floating on the sky, the pride of the captain's eye, as he guides his slender craft inside and opens up the door. On the coast, the long and tempting coast, the cards on the table lie, and a speech so eloquent and rich was made by a passerby, passing by the way between here and left behind me, and it ripples through the crowds who run and cast their doubts in the deep forbidden lake. Yes, it echoes through the crowds who run and cast their doubts in